So many people are filling up in the room. This is going to be really educational. We're going to talk about the vaccine. You're going to get a lot of information from our expert panelists. We're going to go through a slideshow to get that information. And then at the end, if there are questions that have not been answered that you've sent into the town hall mailbox, we'll go through those questions with the panel to answer them. So I'm going to start off by introducing the panel, the team. We have Dr. Landers, who's on. And he's going to be speaking in a minute, so I'm going to go through the rest of the group first, and then he can introduce himself. We have Ellen Gussick. Want to introduce yourself, Ellen?
Hi, everybody. Good evening. Thanks for joining. You all know me as the Chief Nursing Officer. Thank you.
And we have Dr. McCoy on.
Good afternoon, everyone. I'm Christine McCoy, the chair of the Children and Family Health Institute.
And we have Dr. Leonard.
Hi, everyone. I'm Sarah Leonard. I'm the medical director for Visiting Physician Services and the special COVID-19 medical director for Home Health and Hospice.
Thank you. And we have Bet Rosa.
Good afternoon, everyone. Bet Rosa, your Chief HR Officer.
And Jennifer Carroll, who you just heard from. You can say hi again.
Hi, everyone. Director of Strategic Initiatives. Thanks all for joining. I'm just behind the scenes for this.
Great, thank you. And Dr. Landers, I'll let you introduce yourself and give us opening remarks.
Thanks so much. Welcome, everyone. Happy New Year. It's 2021. It's great to get to be with all of you and to spend a little bit of time together on an incredibly important topic. So I just want to set the stage of why are we here? Why are we here? And it's really there's one main, big, important reason, and it's because we are really focused on the health and safety of our teams, of our people. We have, at every step of this pandemic, wanted to focus on our teams, all of you, our people, and your safety and well-being. And thank goodness we are at an incredible moment here where science and technology have created what looks to be a very strong solution to this pandemic, which is a COVID-19 vaccine. And we want everyone to get the vaccine, assuming you don't have any, personal medical contraindication or something, individual that would get in the way. We'd like you, if you can, to get the vaccine. It's optional, but we think it's really important. But we know that decision is one that you all have to make and get as much information as you can. And so the purpose of today really is just to provide as much information as we can about the science of the vaccine, where we're at with this pandemic, and so that you can learn as much as you can. I got the Pfizer BioNTech first dose of the vaccine actually a couple weeks ago. I'm getting the second dose next week. I didn't really have any side effects from it. A little bit of a soreness in my shoulder has been my experience. But just want to encourage you all to learn as much as you can, and that, know these vaccines save lives and they can protect you. And we want you to be safe and protected and be as healthy as possible. Also, some of you may already have received a vaccine or are planning to, and you just want more information. Hopefully, eventually, we're going to be in the business, VNA, of helping people get vaccines, community members, and you're going to want to be able to advocate for them. We're not at that stage right now. And this presentation is not about our plans to vaccinate patients or anything like that. This is really about informing you all from an employee health perspective about the vaccine. So welcome. We have our incredible primary care and public health physician experts that are members of our VNA team here to give you more information. And we've got our Chief Nursing Officer, Ellen Gussick, and I'm going to hand it to Ellen to share her thoughts on this topic. But again, we're here to provide information and education.
Thank you, Dr. Landers. We're all going to echo the same sentiments. Again, we're here tonight to talk about the vaccine, give you as much information as we have that we think is relevant, and also just to remind everyone that safety is number one of all of you. That's all we worry about. So we're going to start with this first slide. Really, it's just an attention getter. It's to talk about COVID-19 and the magnitude of it. We all know it, but when you see these numbers, it's kind of a blaring alert, right? So in the United States, it's 22 million cases just about, and the death rate is 370,000 lives. So that's why we're here tonight, to go into the details. We've listed out New Jersey, Ohio, and Florida as well, but I'm not going to spend too much time on the numbers. We know this is a big problem, and we now have a solution. So I'm going to hand it over to Dr. Leonard, as she has introduced herself as our medical director and has been extraordinarily helpful weekly with managing thousands of patients, right? 1,500 patients in home care and hospice with COVID. So she has become our internal expert. Thank you, Dr. Leonard.
Thank you, Ellen. So I'm going to talk to you this evening specifically about how the Pfizer and Moderna vaccines actually work. But I'd like to begin a little bit more broadly. So all vaccines stimulate the immune system to recognize a threat before that threat actually shows up. The current COVID vaccines, both in use and in various stages of clinical trials, all stimulate the immune system in one of four ways. Some by a synthetic piece of virus, like the hepatitis B vaccine does. Some with a weakened virus, like the MMR vaccine, or a killed virus with the rabies vaccine. A couple by packaging the important material in a virus that's harmless to humans, like the Ebola vaccine. That's actually, you've probably heard about AstraZeneca and J&J. That's the mechanism that they're using. Or by using a piece of genetic code, genetic material, RNA, messenger RNA, like the Pfizer and Moderna vaccines do. So those are the ones that we're specifically going to talk about, and they're the ones that we don't really have another vaccine out there that's doing the same thing. And that's why I think it's important to talk about them and understand exactly what they do inside the body. Next slide, please. So the way these messenger RNA viruses work is through, well, let me back up a little bit and start. So the virus that causes COVID-19 has these spike proteins on its surface. And I'm sure you've at some point heard about these spike proteins. They're really the key to the virus getting into the cells and causing infection. So we have experience with these proteins from the SARS and the MERS viruses that have been studied, and that's well over a decade of experience. So back in January, when the genetic code for the virus that causes COVID-19 became available, it was very easy to identify the part of the sequence that codes for these spike proteins. Think of it like a blueprint. So if the virus were the house, right? So the blueprint is for the entire house, the entire virus, the roof, the walls, the plumbing, the wiring. We're just looking at the back deck. So they're just really extracting that piece, that small blueprint for the deck. So it's not going to recreate the whole virus, just a piece of it. These spike proteins are essentially like the deck, okay, in my analogy. So that's the thing that's going to be used to stimulate our immune system. So we want to they're going to take the blueprint to make these spikes and get them into the body. And the body is going to then follow that blueprint and make these spikes. And that's the thing that's going to stimulate our immune system. Now, the thing with messenger RNA is that it's kind of fragile. It doesn't hold up very well. It degrades very fast, which is a good thing because we're putting it on our body and we don't want it to last too long. But we need a way to get it into the body and into the cells without it breaking down ahead of time. And the way that's done with the Pfizer and Moderna vaccines is by putting it in this lipid nanoparticle. Basically, it's a bubble of fat, and it helps it get inside of our cell. So if you could go to the next slide, please. So as you can see from this slide, these particles, they bring this little teeny tiny piece of blueprint. Remember, it's not a blueprint for the whole virus. It's not the whole house. It's just a little piece, the deck, and it brings it inside. And inside the cell, we have mechanisms called ribosomes that are going to translate this. So they're going to follow this blueprint and they're going to build the thing that it gives them instructions to build. In this case, it's the spike protein. And it takes 3 of these to make one of those spikes that cover the surface of the virus. So next slide, please. And then those spikes and pieces of those spikes, they leave the cell, they protrude through the surface, and then they also, when the cell dies, they get released. If you can see here, the nucleus of the cell, that's where all of the important things, that's really the operating part of the cell. That's where our genetic material is stored. None of this goes in there. So that's an important thing to keep in mind. Nothing gets in there. So this isn't reprogramming our own DNA. This isn't affecting anything in the workhouse of our cells. It's staying outside and it's getting degraded very quickly. The cells are breaking down very quickly. And as you can see, the only thing that was made inside the cell is those proteins, not the virus. Okay, so it never goes into the nucleus. This blueprint is not making a virus, just one piece of the virus. And the cell is going to break down and get rid of the mRNA very quickly after it's done using the instructions. Okay, next slide, please. So those spikes, the debris from the cell, is picked up in our immune system by these cells called antigen presenting cells. And what they do is they engulf it and they carry it through our bodies and they present it in a couple of ways. So one of those ways, next slide, please, is by giving it to a helper T cell who then gives it to a B cell. Now, B cells are really important because they're the ones who make antibodies. Okay, and these antibodies are made perfectly for these surface proteins. So they recognize the surface proteins and they bind to those spikes. Okay, those spikes that are the things that enable COVID to get into our cells. They bind to them and they keep them from being able to get into our cell. It essentially neutralizes the virus, makes the virus inactive. Once they find the virus and attach, the virus can't do any harm anymore. And then there's also B cells that remember. They remember it for next time. And so when they see that again, you know, they know exactly what to do and typically respond quicker and more strongly. Next slide, please. And then another thing, another place that those antigen presenting cells can take these spikes, these fragments, is to these killer T cells, which are another great part of our immune system. I actually had a friend in medical school who had a band named the Killer T cells, just as an aside. But, so the killer T cells, they identify these spikes on the surface because they have been taught, this antigen presenting cell has given them this information, and they've been taught that they need to recognize this, and they just kill those cells. So they will kill those viral cells. So we have kind of two things going in our immune system, two processes that this vaccine stimulates. Next slide, please. So I just want to, there's a good summary here of most of what I said, if anybody comes back to this presentation, but I just want to hit a couple of key take-home points that I'm hoping you'll come away from this understanding. So these mRNA vaccines, they've been rigorously tested for safety before being authorized for use in the United States. And Dr. McCoy is going to talk about that a little bit more. And although this technology is new, it's not unknown, like I've mentioned. They've been studying these proteins in the SARS and the MERS viruses. So this ability to isolate this small piece of blueprint is not new. The vaccines do not contain a live virus. I've said that a few times, and it does not program our cells to make the virus, just that small piece of the virus, remember the deck. And then it never enters the nucleus of the cell. So it does not do anything to our own genetic material. It doesn't get involved, and it's degraded and broken down and gotten rid of very quickly. Okay, so with that, I'm going to turn it over to Dr. McCoy.
Thank you so much, Sarah. I realized, everybody, I should have introduced myself as I'm the person whose name is on your COVID test. So I want to give everybody a shout out for being so amazing in our COVID testing protocol and allowing us to have it be self-service, which is just working so well. So thanks all of you for figuring out, and coming into the building and getting your tubes and going back out to your car and coming back in. I know it's a lot of running around, but it is working really well. And as you are about to hear, we're not ready to give that up yet. So we need to keep doing it. And so again, thank all of you for really playing along with making sure that we're keeping each other safe with our checking up on each other with the COVID testing. So as Sarah said, I'm going to switch and talk a little bit more about the testing of these vaccines now that you have a really detailed understanding of how they work. And I wanted to start by talking about the fact that, these are not what we would typically call approved medications. They are both operating under what is called an emergency use authorization, meaning that there hasn't been time for them to go through, years and years of large scale testing in humans, which is typically what happens before a medicine is given normal FDA authorization. Because it's so important for us to have access to these vaccines, they are given an emergency use instead of the normal approval process, which really just means that the time has been shorter. And because the time has been shorter, there are many questions that you are asking and everyone else around the world is asking that we don't know the answers to yet. And we'll kind of walk through those as we go along and talk about what we do know and what we will know over the coming months as we have more time and more experience with these vaccines under our belt. But what is really important to know right now is that they have been tested in lots and lots of people, and we'll talk about that. And they really seem to be very effective at reducing the risk of having a symptomatic case of COVID-19, either a mild case, and they're amazingly effective at reducing having a severe case of COVID-19. So that is really the biggest take-home message here, is that out of the 32,000 people in some of the original studies, only one person who had been fully vaccinated ended up hospitalized. So we're going to walk through that in a little more detail. If we can go to the next slide. This is, again, we're not going to read this, but this is in the slide deck so that later, if you want to understand more about what an emergency use authorization is, here's your detail. So we're going to go to the next slide. So, and here's the basis for making the decision for the emergency use. So we're really looking at benefits versus harms of something that is not, again, completely studied for many years. We know that the anticipated effects, the benefits are large. And if we go to the next slide, the harms based on the half a year of testing this vaccine are very small. So given that large benefit, the small harms, thus we have the current authorization. So the next slide shows us really a quick summary of what happened in the first set of studies. So these are the studies that were used to give us the emergency use authorization. There are many other studies with many more thousands of people currently underway. So the numbers that you see here are just the beginning. So if you look at the Pfizer vaccine, the studies that led to the authorization for use, they had 20,000 people getting the vaccine and another 20,000 people who got a placebo shot. For Moderna, same thing, 14,000 people got the Moderna vaccine and another 14,000 got placebo shots. And these numbers reflect the people who completed the series. So they got both doses. And then if you look at what happened, how many people got a case of COVID, and the way they defined a case of COVID was having symptoms plus a positive RNA test. So we're not talking about asymptomatic. That piece is still being worked out. But in terms of people who got sick, even just like sniffles, conjunctivitis, a cough, anything like that. Of the 20,000 people who took Pfizer, of those who had had 2 vaccines, only 8 got any type of COVID with symptoms, whereas 162 people who got the placebo shots got symptomatic cases of COVID. And then if you look at how many of those got very sick, there was only 1 person who got very sick after having 2 doses of Pfizer versus 4 people who got very sick after having 2 doses of the placebo shot. Looking at the Moderna, the numbers are very, very similar. 11 people got a asymptomatic case of COVID versus 165 with the placebo, and no people got very sick after getting 2 doses of the Moderna shot versus 30 people who ended up with severe cases after the placebo. So that's pretty good. You know, again, this is not telling us about the asymptomatic cases. I do want to emphasize that data is still being analyzed, where people were tested with an RNA test but said they had 0 symptoms at all. But this is looking at people who actually had even 1 or 2 symptoms, depending on which of the studies we're looking at. And they looked at what happened after just 1 shot. So with the Pfizer, they were able to find that it was 52% effective after just 1 shot. And then once you got 21 days later, you got the second shot, it went up to 95%. And this was basically true regardless of who you were. They looked at different race and ethnicity categories. They looked at different age categories, and essentially it was the same. There weren't a whole lot of older people, interestingly, in the Pfizer trial. So the numbers were just weaker from a statistical standpoint for people over age 65. But it still looked very, very good. And the way you can tell how good this was is, for those of you who know anything about stats, I put the confidence interval there. That's what's in the parentheses. This is an amazingly tight confidence interval. So this really shows you this is a very robust, because the uncertainty band is only from 89.8% to 97.6%. So somewhere in there is the truth of the effectiveness of this vaccine. Oftentimes you see studies and they might have some great looking number, but then you look at the confidence intervals and maybe it's like 40% to 98%. So then you're like, well, maybe it's only 40%. So that's not so great. But in this case, we really know it's really, really good in terms of preventing symptomatic cases of COVID. On the Moderna vaccine, they had so few people studied after just 1 dose that they don't really know what the effectiveness is after a single dose based on the first set of studies. There's more studies coming along, and you may have heard that in Britain, they're talking about, just getting that first dose out and not worrying about, exactly when people are going to get their second dose. And in part because on the little bit of data that they have, it looks amazingly effective. So take this 80.2% with a grain of salt, but it may be that good after 1 shot, possibly. But after 2 shots, and in this case, it's 4 weeks apart, 28 days for the Moderna vaccine was the way that they tested it. It goes up to essentially the same, 94.1%. They looked at it starting 14 days afterwards. Pfizer looked at it starting 7 days afterwards. Again, this is just how they chose to look at it. It doesn't really mean that Pfizer is quicker than Moderna, but it's the way they chose to study it. So we just wanted to tell you that that's what the data is based on. And if we look at the next slide, you can get a really nice graphic of what happened with the Pfizer vaccine. So if you're looking at the blue line is the people who got their vaccine. And then the red dots are the people who got the placebo shots. And look at just how they just kept getting COVID and kept getting COVID and kept getting COVID, right? Like it just kept over this study time period of almost 120 days. If you got placebo shots, people just kept getting COVID. If you got the Pfizer at the beginning, when you only had 1 shot and before it was fully functional, you might get COVID. You can see that the lines were the same, but then very, very quickly, even before people got to their second dose on day 21, which is circled in red down at the bottom, it already, you can see how it was starting to work really, really quickly. And then it just stayed flat. You know, people got their second dose and very, very, very few people got cases of COVID. Really after about 10 days after their first shot, and for sure after the second shot at 21 days. Over time, will we know exactly, you know, is there a better interval for taking these shots? Can the Moderna shot be cut in half? You've probably heard rumors about, can we cut the dose in half of Moderna because you don't really need that much? We're going to know all that stuff with time, but for right now, this is what we know about these vaccines. Let's go to the next slide. I wanted to compare how good these vaccines are to vaccines that most of us get every year, which in this case is the flu vaccine. So you saw those numbers, 94.1%, 95%. This is what we've had over the last decade and a half in terms of how good the flu vaccine is. And the best year you can see was 2010, 2011, where it was 60% effective. So, so this vaccine is so much more effective based on what we know right now than the flu vaccines have been. So it just, you know, sometimes people go, well, I got the flu shot and I still got the flu. Well, yeah, there's a pretty good chance you could still get the flu, but it looks like there's really only a 5% chance that you would still get a symptomatic case of COVID after getting the COVID vaccine. So, so much, much better. Let's go to the next slide. So I've talked about this a little bit. There are things we don't know yet just because this is so new. So they're still crunching the data about the asymptomatic infections. You know, people who got a positive test, but just said, no, I feel fine. I have 0 symptoms. So we're still trying to understand that. And we're also, because so few people got a case after they were vaccinated, there haven't been a whole lot of opportunities for those people to even try to transmit it to somebody else, which is why we don't know. If you're one of that 5% and you still get COVID after getting vaccinated, could you give it to someone in your family? Maybe, maybe not. We don't know because the numbers are so small. It takes a long time to study it. So, but it is important to know that these two things are not known, which is why, unfortunately, you know, you're not perfectly protected, obviously. You still have a 5-6% chance of getting a symptomatic case, and maybe you could get an asymptomatic case, maybe you could pass it on. So unfortunately, those masks and all the other PPE don't get to go away at this point. We'll talk about when they can go away, but you know, just because you've gone and gotten your 2 shots, unfortunately, you can't stop wearing the mask and the eye protection and all of the other PPE. Let's go to the next slide. So I know because this is new, you know, we have to be concerned what could happen. And this is true with anything. Every time we take an aspirin, an Advil, a Tylenol, whatever, there's potential harms that can happen to us. So it's really important that we understand, you know, what might happen, and that we also become part of the system for learning about adverse effects after the vaccine. And we'll talk about that at the end. But so far, so good. There are, if you look at people who got placebo versus people who got one of the 2 vaccines, there was very few people who had something bad happen to them, like a Bell's palsy. Very few additional people got it. So there's people who got placebo vaccine and they got Bell's palsy. And then, you know, there were a couple of people who got the vaccine who got it. Actually, I think there was really actually only 1 reported case so far of Bell's palsy, but so that probably wasn't the best example. But of the kinds of things that get reported as serious adverse events, they basically are happening at almost the same rate in people who got placebo versus vaccine. So that just means a statistical chance for the most part that these things are happening. Now, there's some things that are clear vaccine reactions, right? Getting anaphylaxis right after you get the injection, we all know why that happens, versus a Bell's palsy that happens 30 days later. So, and in this case, again, you can see that some of these things still just randomly happen to people. But of all the severe reactions, what they call a grade 3 or greater reaction, 8.8% of people did have something that fell into that category. Now, please be aware that doesn't mean that they had anaphylaxis. There's things considered severe reactions that fall far short of anaphylaxis. And in fact, the number of anaphylactic cases through the month of December were so low, they were only reported at this point as being about 21 cases around the whole country of everybody who got the vaccine in December, including myself. So, and again, some of these reactions just happen for other reasons. You know, somebody has a allergic reaction to nuts or something like that in a fairly close time frame. Let's go to the next slide. So we can come back to the reactions, but we want to talk about things that help us to optimize not having a reaction and having the vaccine work as well as possible. So one of the things that, again, is based on, you know, best educated guess is don't get this vaccine right after you got another vaccine, in part because that might have your immune system so revved up that A, you might have more of a reaction, or B, your immune system is just overloaded and might not react perfectly to this one. So if you just got your shingle shot, for example, you need to wait for 2 weeks before you get your COVID vaccine. So pretty simple, and we'll have plenty of vaccine available for somebody if they just got another vaccine. So if you got your tetanus, you got your shingles, we can wait a couple weeks and then get it to you. And then on the other hand, if you, for some reason this happens anyway, I don't know why it would, it's not a big deal. You don't have to go back and get revaccinated. Let's go to the next slide. So what if you've already had COVID? And unfortunately, a fair number of us have. So the best evidence suggests that it's still a good idea to get the vaccine. We do know over time from people who've enrolled in studies that their antibody levels go down, and there have been a very small number of people who have documented second cases of COVID. And at least one of those people who got much sicker the second time around than they were the first time around. And so because of that, it seems like it's a good idea to give your immune system a boost by getting this vaccine. So you don't need to get tested to check whether you had COVID before if you're not sure. So if you had it, you didn't have it, either way you should get it, but you don't want to get it right away because we know you have really good protection for at least 3 months. So the current recommendation is if you've had COVID in the last 90 days, we're going to ask you to wait. But starting at 90 days after your infection, we do recommend that you get the vaccine. And for you, it's more like getting the second dose. It's more like that booster dose. But right now, we're still recommending that you get the second dose as well. Let's go to the next slide. If you have COVID right now, please stay home. Just going to leave it at that. So stay home, do what you're supposed to do. 90 days later, we're happy to give you a vaccine. Let's go to the next slide. All right, what if you got antibody therapy when you had COVID? The bottom line is there's not enough people that have been studied. So we don't know, but based on what we know about how the antibody therapy works, we're just going to assume that, again, you should wait for 90 days so that you don't have, quote, interference of these two processes. So but just like you wait 90 days after your COVID in general, extend that maybe a couple days to the date of when you had antibody therapy, and then you can get your vaccine after 90 days. Let's go to the next slide. So what if you are pretty sure you got exposed to COVID yesterday and you're scheduled to get your vaccine tomorrow? What should you do? Well, stay home. You know, so if you are quarantined, if you're in that circumstance that you're allowed to and it's okay for you to stay home, then stay home. On the other hand, if you had an exposure and we're not worried about it so much that we're still telling you to go to work, then yes, please go get vaccinated. So the same thing, you know, if there is an outbreak in a nursing home, in a jail or prison or any other sort of congregate, and, you know, lots of the staff there were exposed, this is the perfect time. We want to get them all vaccinated. So it's really just a matter of risk. Like if you're still out and you're still working and you're wearing your PPE and you're doing all these things, but you have a possible exposure, but we're still asking you to work because we really need you to work, then yes, go ahead and get your vaccine. If you're able to stay home, then stay home till that possible period of you coming down with COVID and then recovering from it is completed. And then you can get your vaccine afterwards. Now, we've had a couple of people get their first vaccine and then realize a day or two later that they had COVID. I think we've actually had 4 people that that's true of so far. So, just bad luck. The bottom line is we're just telling them to wait 90 days before getting their second shot. What if you have underlying medical conditions? Well, that's probably the best reason for you to get a COVID vaccine. So it seems to work really well in people with a pretty wide variety of underlying medical conditions, including the things that might make you at risk for getting a really bad case of COVID-19. So it is not a contraindication to have just sort of general underlying medical conditions. In fact, it's a really good reason for you to get the vaccine. Next slide. Now, what if you're immunocompromised? So bottom line is we have not studied all the subgroups of people with different types of conditions, but we do know, of course, if you are immunocompromised, if you got COVID, that could be really bad because your immune system that Dr. Leonard walked you through might not be working optimally. So again, definitely recommending to get the vaccine. But if you're taking a medication that makes you immunocompromised, you probably do want to talk to the doctor that prescribes that medication for you so that they can look at the mechanism of that medicine and give you a sense of whether the vaccine might not work as well for you because of the type of medicine that you take. And there is some certain medicines where maybe the mRNA vaccine might not be the optimal vaccine, but some of the vaccines that are coming down the pipe later might be a better vaccine for you. So maybe you might end up getting vaccinated twice, but it's still very unlikely to be a reason not to get the vaccine. It just means you might need to get another vaccine or get a booster or something down the line because your immune system is not working quite as well. So again, if you're on a medication that makes you immunocompromised, then I would recommend having a conversation with that doctor who prescribes you that medicine, just so that you really understand everybody's best guess about how that might affect you in taking the vaccine. Let's go to the next slide. What if you're pregnant or breastfeeding? So again, like everything else with COVID, we don't have a whole lot of data yet, but in terms of safety, there's ongoing studies in pregnancy. There's ongoing studies of breast milk. If you're lactating and you get the vaccine, maybe you can sign up to be in one of these studies. But the bottom line is that if you are at risk of COVID-19, which if you are one of our employees who works in the field, you clearly are, the current recommendation from ACOG and the Society for Maternal Fetal Medicine is that it is, that you should seriously consider taking the vaccine. That there are not enough concerns to say don't take it. And same thing in breastfeeding. So if you are at risk because you have to be out and about and in high risk situations, all the professional societies are saying that it's fine to go ahead and take the vaccine. So on the other hand, if you truly are working from home, you can stay at home, you don't have to even go out to the grocery store, you might choose to defer taking this vaccine because you're in such a bubble that your likelihood of getting COVID is next to nothing. So it's a very individual decision, obviously for everybody, but particularly in pregnancy and lactation, you really have to look at the risk factors in your life and take this decision. I can tell you, being part of a couple of Facebook groups of physician mothers, that every physician mother in the field who's at least writing about it on Facebook is taking the vaccine. Whether they're pregnant or whether they're breastfeeding, they are all choosing to take the vaccine because they're so scared of what can happen to them if they get COVID while they're pregnant or breastfeeding. So the decision of these many female physicians is to go ahead and take the vaccine. But again, they're at risk and you may not be. So you make that individual decision. So what can happen when you take the vaccine? So you should obviously, get some information about that, and we'll talk about that in a minute. But it should be happening, at the time that you get the vaccine, and we really want you to be prepared to come back for the second dose of the vaccine, unless, of course, you have a very severe reaction to the first dose. So if you're worried about getting a fever, getting a sore arm, any of those things, should you take medicine before you go to get the vaccine to block it? The answer is we're asking that you don't, in part because we're trying to get the real numbers of people's reactions. Now, if you go and you get it and you get a fever or you get a really sore arm like I did, you can definitely take that medicine later. That's perfectly fine to take the medicine later. But the point is that right now we're all investigators. We're all part of the story of understanding what happens. So, so we don't know if taking an ibuprofen or a Tylenol ahead of time might have an effect on it if you took it ahead, but we're sure that it's okay to take it afterwards. So just hold off, see if you get a reaction, and then take your medicine afterwards if you need it. Let's move to the next slide. So what could happen? So really common things that happen, it's similar to getting your flu shot or shingle shot, pain and swelling at the injection site. I mentioned I had a lot of very sore arm that same day, later in the day, but by the next day it was completely fine. And I personally had no swelling at all. So just a sore arm. Some people have had some fever, some chills, some headaches, some fatigue. And almost everybody is reporting these really in that first 24 hours. I've heard a couple people say, 3 days later, I suddenly felt tired and I didn't have another explanation. So maybe, but really it tends to be pretty quick and pretty much over within 24 hours, the common reactions that people are having. Let's go to the next slide. So who shouldn't get this vaccine? Well, if you look at the package insert says, if you have had a severe reaction to any component of this particular vaccine, and this one's from Pfizer, don't get the vaccine. Well, you probably don't know whether you've had a severe reaction to anything that's in the Pfizer vaccine, because as Sarah talked about, this is a very new type of vaccine with different components. It's not similar to any of the vaccines that any of us have had. So I don't really find this information on the package insert to be very helpful, except of course, if we're talking about your second dose. So really, what should we do? If we want to go to the next slide, the reality is if you have had an anaphylactic reaction to any vaccine or any type of injectable medication, for right now, we want you to sit this one out. It's just not worth the risk. Let the rest of us take the vaccine and try to create the herd immunity to protect you. Again, this is new. It's only been out since the middle of 2020. So let's not have you take the risk if you have had that severe of a reaction in the past. And if we look at those 21 or I can't remember 20 odd people who had an anaphylactic reaction in December, the vast majority of them were people who had a history of anaphylaxis in the past. So it's the same people who've had anaphylaxis to something else, some other type of injected medicine or vaccine, it's happening to them again. So again, sit this one out if that is your personal history. If for some reason you still want to persist and do it, for sure we want you to be observed for 30 minutes. And I think really this is more people who've had maybe anaphylaxis to something else. So food allergy, for example, you're just a person who's had a single episode of anaphylaxis, but it was definitely not to a medicine. It was definitely not to a vaccine. It's to shellfish. So you want to go ahead and get this vaccine. That totally is logical and that makes sense. Go ahead and get the vaccine, but we're going to ask you to tell them that when you get the vaccine and they should be monitoring you for 30 minutes instead of just for 15. For everybody else, for sure, you're going to be sitting there At RWJ Barnabas, they have 1 million little egg timers, at least at Monmouth Medical Center. They're set up with 1 million egg timers, and you get your own personal egg timer, and when it goes off, they let you go. So different setup at different places, but people are being very careful about this. And of course, they're ready to react should anything happen to you. So standing by with all of the emergency medications that are needed. Let's go to the next slide. So what should happen after you go and get your vaccine? Well, they're going to give you a little card, and it's going to show your lot number, and it's going to have your name on it and the date that you got it. Please, please, please try to remember to hold on to that card and to keep it. And take a picture of it and send it over to Employee Health. Because right now, we don't know that you have gone to RWJ Barnabas or somewhere in Florida or somewhere in Ohio to get your vaccine, because of the way that the whole setup is and the fact that it's being, sent to different organizations and billed through insurance, et cetera. So, so we need to know that you got your vaccine. We're not getting a report back from the different places in the 3 states. So please take a photo and zap it on over to employee.health@bnahd.org. Then what else can you do? If you get side effects, we want you to be part of us learning about side effects, as I mentioned. So there is a system for reporting severe side effects called the VAERS system. Some of you may be familiar with it. And on the slides, this is the information. There's different numbers for both Pfizer and Moderna. And then there is reporting directly to the government. But what if you just get headaches? Maybe you get a little bit of rash, something like that. Let's go to the next slide. This is going to show you how you can be part of our system about learning about this vaccine. So the CDC has set up this program called vSafe, and you can see this little QR code. So after you get your vaccine, while you're sitting there waiting your 15 minutes for your egg timer to go off, you take your phone, you point it at this little QR code, you tap on the link, and you register yourself to be part of this system. And what will happen is that they will send you little surveys, like 3 or 4 question surveys. And they typically send you one that same day that you got your vaccine, and then daily for a few days, and then it goes to weekly. Like I'm in the weekly section now. So once a week I get, a couple of questions that come, and they ask me about any symptoms that I have. And so that's how we all can contribute to really better understanding what's happening to people after they take this vaccine. Next slide. So again, this is just more of the information. So you'll have the full reference when you get the slide deck. So what happens if you'd like to have a vaccine and you're not set up for it yet, and you don't have an email inviting you to get it somewhere? Please go ahead and email, not Employee Health, but this time Employee Engagement, and let us know who you are, and most importantly, what's the best way to get a hold of you. If it's a phone number, can we text that phone number? Please give us that information so that we can get back to you as quickly as possible and let you know what is the best way for you to get a vaccine, because depending upon where you are, the answer is different. As it says here at the bottom, we're really encouraging everybody, as Dr. Lander said, to get this vaccine scheduled, to get this vaccine as soon as you can, because the sooner we get to this herd immunity, then maybe we can stop having to wear masks. So, right now you're protecting yourself, and because you're not going to be really sick, that's going to be of a huge benefit to you. But because we don't know yet about having possibly an asymptomatic infection, being able to spread it to other people, we're not ready to give up those masks and all the rest of the PPE yet. We're not ready to jump on a plane and go anywhere yet with 100% confidence. Yeah, you can feel better about yourself not getting sick, but could you still show up and infect people on the other end? Yes. So I've had a few questions come asking people, can they go visit their grandchild? Can they go visit their elderly parent? Can they finally go on that vacation? well, if you're going to go on that vacation and stay, in a cottage all by yourself, I suppose you could do that. But if you're going to go visit that elderly parent or visit that grandchild, you will have a lot less risk than you would have before, but you're not at the no risk. And certainly you need to be following all the same precautions that we've all been following since March. So, so we're not out of the woods yet. So I know we've got a few more questions, and Jenna's been popping up some additional questions. So Sarah, have you been looking at the questions? Are you ready to answer some of the ones that have come in during the talk?
I've been looking at some of them. There's something that I forgot to mention, and it's been a question that came up again, but a question I've seen previously. There's a question about the new strain, and they're asking, is the vaccine going to be effective against that new strain, the one in England, and that's been identified in certain places in the United States? So the answer to that is, remember, the vaccine trains our immune system to recognize those surface spikes, those surface proteins on the virus. So as long as any strain variation has those same spike proteins, then the vaccine is going to be effective against them. And from what I've read, and there's new information every day, but it does seem that the vaccine is effective against that strain that's been identified.
Great. I know we had a lot of questions that came in to the town hall questions. So I'm going to just look through some of them that we haven't already covered. A lot of them were already covered, and thank you so much. It was great information. I know we covered already about wearing N95 and face shields. I just want you to maybe reinforce the need to do that, because that's a question that came over a lot.
Right. And, I mentioned the herd immunity, and maybe we should talk a little bit more about that. So what we're all trying to get at, and I know if you've all been following our new celebrity, Dr. Anthony Fauci, like he talks a lot about this. And so what happens when we have a vaccine is when we get it out to a certain percentage of the population, and that percentage of the population varies depending upon the transmissibility of an illness. So unfortunately, this new UK strand is bad news in terms of herd immunity because it's easier to pass on. But so for things that are very easily passed from one person to another, you have to get to a very high level of the population, like 80–85% of people have to be vaccinated before it can't easily jump to a new person and keep going around in the community. If it's a disease that's very hard to transmit to another person, sometimes you can get to herd immunity when you have 50–60% of the population vaccinated or otherwise immune. So, now unfortunately it seems like the numbers are climbing in terms of what we need to get to that herd immunity. So that if you imagine 100 people crowded into a room, and one person has COVID, if that person is near them, we know that they're at risk. If that person is all the way over on the far side of the room, so say we've got this 95% effectiveness, you've got 5 people, say we got to 80%. So we've got 20 people in the room that have not been vaccinated. So it kind of depends on where they're standing and how easy it is for this to get to them. So that would depend on a lot of factors. If we're all outside, it's summer again, we're all outside, it's not very likely that virus is going to get, to those 20 people. But if we're closed up in a room and the room doesn't have good airflow, and we're all in there for a couple of hours, then again, it is likely that is going to get to some of those other people. And so we're going to continue to have COVID in the community. So I think, what we're all trying to aim to is get to as high level of people being vaccinated as possible, over the spring and early summer. Then we get the benefit of the good weather where we can all spread out and get away from each other more. And then that might be enough to just let COVID die out if we're lucky. If we're lucky, that's what will happen. And it doesn't mean that it'll be 100% gone. It might pop up in little bits and pieces here and there afterwards. But that's where we can get to that point where we might be able to move away from all the PPE. So that's really what we're trying to aim for. For now, it's the combination, all the things that we've been doing plus the vaccine.
I'll
Great.
just
Thank
add,
you.
this is Beth. I'm just want to add a little bit to that. So, in employee health, we're going to continue to follow the CDC guidelines and the Department of Health guidelines from the states. So when they change those protocols that we're following, that's when we will relax, maybe the PPE or visit protocols or things. So, that's also something that we're looking at, is those requirements that come from CDC and the 3 states that we're operating in.
Great. And Bet, while you're there, there's a couple of questions that I think are good for you. One is, will the vaccine be mandated? And part 2 of that is, will I be fired if I refuse that?
So right now, no, under an emergency order, there's the vaccination is not mandated. However, when we made the first announcement, we said, hey, there's a caveat to that. So at some time in the future, it may be just like the flu vaccine, but right now it's not. Nobody has made that decision, but I just want to leave people with the opening that may happen sometime in the future after we learn more. And again, we're going to take that from the CDC and from the Departments of Health of what's advised and what the requirements are in the future.
Right. And, within each business unit, depending on what kind of jobs people have, we say you can come back to the office, you can go out into the field if you've had the vaccine, maybe not. Again, all this knowledge is just sort of evolving and we're waiting to get official recommendations. But there's probably not going to be a blanket recommendation for the whole company. It'll probably depend, really on what business unit you're in, what your job is, whether having had the vaccine makes a difference to you, particularly in the short run, in terms of whether we say, okay, yep, you can come back into the office. So we're still figuring that out, but it is definitely something to keep in mind. So someone asked a question about what happens if you get the first shot, but then you didn't get the second shot on time when you were supposed to. Is there a time where you would have to start over again? It's a great question, and it's one of the questions we don't have an answer to yet, because again, this just hasn't been around long enough to know. So I'm sure that there are some trials underway that are looking at that scenario, like how quickly does the protection from the first shot, drop off, and would you have to start all over and do the 2-shot series again? So I just recommend trying to get your second shot, within, close to the recommended time. Obviously, there's no true magic to 21 and 28 days. Those are the intervals that were used for the study. It helps us to keep track of everybody to get this done. But, sometimes if you got your first shot on a Sunday and then they're no longer running a Sunday clinic a month later, you might get it on a Monday. Is that the end of the world that you got it 29 days later? No, that's obviously that's okay. So really try to get that second shot, as close as possible to the recommended interval, 21 days for Pfizer or 28 days for Moderna.
And Dr. McCoy, there's a question that's very similar to that. Once you get the second dose, how long will you be protected?
Right. So again, not fully known at this point in time. In general, with both actual COVID disease and the vaccine, they see a really good antibody response out 90 days. And of course, they're continuing to follow that, and they'll let us know when it drops. But the fact that it drops may or may not be a problem. Like, there may be some of you out there like myself who don't have a detectable hepatitis B titer at this point in their life. But we've had a detectable hepatitis B titer. And if we got exposed to hepatitis B, our immune system would zoom into gear, do all those things that Sarah was talking about, and protect us from hepatitis B. So we don't need to have a whole other hepatitis B series, as long as we can prove that we had that correct response, back in the day when we originally had our vaccine. So this could turn out to be like that, or it could turn out to be the scenario where once your antibody titers drop down, then you really aren't protected. So again, both the humoral immunity, all these different aspects of the immune system, they're all being studied right now, and we should know them within the next year, but I'm hoping that we don't really have to worry about COVID a year from now.
Great. I have another couple of questions about when will they start rolling out to low risk and the general public, and actually all the way down to a couple of questions about when will our patients be able to get that.
So we don't have a timeline of when that's going to happen. That's not known ahead of time. What we do know is right now that some of our low risk employees are receiving the invitation from RWJ, and we expect that everyone should be receiving that probably by early next week. And if you haven't, on Monday, the 11th, if you have not received an invitation and you want a vaccine, email employee.engagement@vnahg.org, and we will find you a pathway to get a vaccine.
And in that, please make sure you're putting that a cell phone number that is textable, because a lot of the registration for some of the sites go through text. So we want to make sure that you're sending that over to me. You can always ask.
And Lisa, while we're on that topic, someone had asked, do you want a photo of the vaccine card for the first dose, the second dose, or both?
Both, please. Because otherwise I won't know for 3 months who had a vaccine if you wait till the second one. So I want both, please.
And also don't forget to send your picture in to me as well. People like to see the pictures. Then going back to the travel, I know we covered travel and what to do there, but the question is, can I return to work after travel without quarantining if I've been vaccinated?
So again, we're following the CDC and the state guidelines. The state and the CDC have not updated any travel guidelines for vaccination yet. And I believe it's because of what Dr. McCoy talked about. You have to have the herd immunity for that point for the travel to make it have an effect. So until those guidelines are changed at the national or state level, they remain the same for travel.
And then another, go ahead.
I was going to say, I saw a couple of questions about, will we have to have this every year? Might we have to have another one in 6 months? And I think I covered that, but just in case I didn't, again, these are just all questions that we don't have the answers to yet. But, as soon as we know them, we'll be passing that information on to you.
Another question is, which vaccine are we using more commonly?
So it started for people who got vaccinated early on in New Jersey. They were getting the Pfizer vaccine. And so when they go back, they'll get the Pfizer vaccine again. I believe that all or most of the RWJ-Barnabas hospitals are currently giving Moderna vaccine. And people, in New Jersey, who are being vaccinated at the community health center are getting Moderna vaccine now. So it's really a mixture of the two. Are you aware of what's being used in Florida and Ohio?
I believe Moderna is in Florida. Ohio, I believe, was Moderna also. But again, that could change when they get different lots in. We're not guaranteed when you get there what vaccine is. It's, if you're lucky enough to get a vaccine, it's thank you, whatever it is, right? At this point, until there's multiples that you can have access to.
But I will add, whatever you get the first dose of, they will have a second dose of that vaccine reserved for you. So if you start with Moderna, your second dose will be Moderna and vice versa. Don't worry that if you get the first shot of something, there won't be enough of it for your second shot. That's all being accounted for.
That's great, because that was my next question that was put up here. Will it be available? Thank you.
And you have to go to the same place you got the first shot for your second shot. You can't say, okay, I'm going to go to a different place, right? So wherever you went the first time, you have to go for the second time.
Right.
Lisa, could I go through some of these that came through?
Sure.
Because these are people who are on right now, so they may
Sure, go ahead.
be
I think I'm
listening to
done with
see.
my questions anyway. Go ahead.
Okay, wonderful. A question about the AAP putting out a statement or guideline for children. We didn't address that yet, and so I don't know, Dr. McCoy, if you have any guidance on that.
I was looking for the question. Is that up here? Okay.
It
at
is,
this point, the pediatric studies I haven't seen this statement from the AP. So are they asking whether there's going to be one, or are they asking about one that's already been written that I haven't read?
They are asking if they're going to put out, have they put out a statement or guideline for children relative
I
to
don't
the
believe
COVID-19
that
vaccine?
there is a statement, and the reason why is that the pediatric studies are still underway. They did have teenagers in, I think, both Pfizer and Moderna, for sure in Pfizer. There were teenagers, but the studies in younger children are currently being conducted. So at this point, the emergency use authorization is in adults. It's not for children. So there's really no decision making for parents to make for their children quite yet. Sarah, do you have anything to add to that?
No, I agree.
Yeah, so should be, I would, again, the studies are underway. So as soon as there's clarity from those studies, those will certainly be forthcoming. And I haven't heard that there's any negative outcomes in the studies with kids. And for sure, the teenagers that were in the Pfizer study did very well and had, again, the same level of effectiveness as older people did. The only group that maybe looked like slightly lower was the over 65s. But again, A, that makes sense because their immune systems are not quite as active. And B, the number of people over 65 enrolled in Pfizer's study specifically was lower than what you might like to have. Moderna had a more robust geriatric population, and the results look great. So not to worry about the older folks and not being as nearly effective in them.
Thank you. I have another question here is if you recently had COVID and you were not eligible for the vaccine because you need to wait 90 days, will you automatically get notified when you're eligible after 90 days, or do you need to reach out to someone?
You need to reach out. So Lisa's whirling. Wave, Lisa. So the one that's manning employee.engagement@VNAHG, and that's where you would let us know in 90 days that I'm ready, I'm willing, and then we'll find you the correct pathway at that time when you're ready to get your vaccine.
Thank you. I have two questions regarding the rare and devastating side effects that they've heard about the COVID-19 vaccine, and also if you've had Bell's palsy previously, does it make you more likely to have a side effect of the vaccine? So if we could talk a little bit about what those, the statistics on those rare severe side effects that have been seen so far.
Yeah, so again, the numbers through the end of December that have been published were, very, very, very small. This was sort of the post study. These are the numbers of like all of us, all the healthcare workers getting the vaccine. And so that those were very, very, very small numbers of people having severe reactions. And as you saw from the study materials, remember it was 0.6% of people who got the vaccine and 0.5% of people who got the placebo shot. So some of these rare devastating things like Guillain-Barré or whatever, like they just happen in people for a variety of reasons. And there was only a tiny bit more that is possibly attributable to the vaccine itself. So
I just want to add also, when we look at potential side effects and complications in medicine, we always look at the risks and benefits of kind of both options. So you have to, whenever you're looking at the risks, I mean, this is what I did when I evaluated whether or not I wanted to get this, this brand new vaccine and be one of the test people. I looked at the possible consequences of getting COVID, including death, and all of the complications I've been seeing in patients, things that they're lasting effects of COVID. And then I looked at, the potential risks and side effects and complications of the vaccine, and I made an informed decision. And that decision may be different for different people, but, if you're going to look at complications of one side of it, it's also important to weigh the complications of the other side. the potential complications.
Right. And, that's why we started out with the statistics that Ellen presented, to just show that, New Jersey, for those of us who are here in New Jersey, is still the state with the #1 death rate. So it's not been kind in New Jersey, and now the other states are, feeling a lot of what we felt. They may not be having the death rate that we had back at the beginning, but a lot of very ill people. And I think we've all heard about the long haulers as well, too. So people who are having many, many months of continued challenges that are a huge, wide variety of long-term consequences of COVID disease. And, the latest I was listening to was, potential effect on risk of Alzheimer's disease, so it just, everywhere you look, there's reasons to try to avoid getting COVID. Even though we've all seen, plenty of people get mild cases and pull through, you have to make that individual decision, as Sarah said, about, your risk tolerance for potentially getting a very bad case.
I do see a few more questions. The Moderna and Pfizer vaccine have different micrograms of vaccine per shot. Is it smarter for a smaller person to get the Pfizer one or Moderna, or half a dose?
Yeah, so at this point in time, I mean, the difference is not very big. They're both small, volume injections. It is possible that the Moderna recommendation might get changed in the future because it might turn out to be just as effective at a lower dose, but no one's going to give you a half dose right now. If you're getting it, you're gonna get the full dose. And certainly in terms of there's not really like a volume of distribution calculation around this, like there are with some medications, which obviously is whoever asked this question must be used to giving medications where the volume of distribution is an important issue, and we do adjust it based on body size. But at this point in time, everybody gets the same dose. But for sure, don't be surprised if the recommendation of the dosage on the Moderna changes over the coming months.
And then I have one last question, but I think this is for you or Ellen. The volunteers from within the VNA hospice department are wondering whether or not they are eligible for to get the vaccine through VNA.
Yep. So yes, they're eligible, and we're ready to reach out to them now. So Ellen and I will work together with how we identify who wants the vaccine, get the proper information we need, and then we will set them up with a pathway for vaccine. Volunteers are part of 1A for healthcare. So,
and I saw some questions about, when is this going to be available to other people? And obviously we don't have the answer to that, but part of the answer is the quicker the healthcare providers, the people in the 1A group, as broadly defined, get their vaccine, like let's fill up every darn vaccination slot that we can fill up and get this done, because really that's what the state is waiting for. The state is waiting for healthcare workers to say, nope, there's no more of us that want this vaccine. And once that happens, then we move into that next group of people. So, we don't want those nurses sitting there twiddling their thumbs when they could be giving one of us a vaccine and it taking longer for us all, to get vaccinated. And then that is delaying moving into the 1B category. So I know it's probably not happening, but let's just make sure we're efficiently filling every slot, filling every seat, getting our vaccines as quickly as possible.
and the other thing is realize that this is new and there's some ramp up, right? So where CHC now has experience doing this for almost 2 weeks now, where they started out being able to give only 100 a day. Now they're getting that up to, where it's multiples of hundreds and hopefully 500 or more a day. So as we learn the process and be able to get this going faster, we'll be more effective at vaccinating more people quickly. And that's the hope.
Right. And we are definitely putting together our plans to be part of that solution for vaccinating other people other than healthcare workers. So right now, obviously, we're only vaccinating healthcare workers, but on a variety of fronts, we are planning to be able to vaccinate the other categories as they come up in a way that we uniquely as the VNA are prepared to go out into the community, to go to people's homes. We're working on the details to figure that out, but we definitely plan to play our part in making sure that we get this vaccine out to other folks as soon as we're able to.
And I have two last questions. One, is there less of a risk for COVID if you are a zero blood type, O blood type? No, sorry, not zero. O negative. This one was specific to O negative.
Oh, negative.
Sarah, I heard you start to comment.
You know, I just don't think we have enough information to give you a good answer on this.
Okay,
Yeah.
thank you. And then my last question is, folks are wondering if they got one type of vaccine this year, say it's Pfizer, next year, could they get Moderna? Or should it be the same that they got previously?
Based on, you know, our experience with other vaccines, and again, we're keeping our fingers crossed, we don't have to keep doing this vaccine every year, but if we do need to, I would say you'll be able to switch to another one. Again, it's not a known, so don't hold me to it. Don't string me up if it turns out not to be the case. But just like with the flu vaccine, you know, one year you get one manufacturer, another year you get another manufacturer. That that general concept would hold true. It's just that we know from the studies that this particular one, given at this particular interval, works well. So we're not going to mess with that known formula for effectiveness. So that's why we're being very, very careful to make sure people get the same manufacturer for their second dose right now.
Well, thank you so much. Those were all the questions that came through my inbox, through the Q&A inbox, through our chat inbox. So I think we addressed them all. And this is a recording, so we'll be sure that we distribute the slides broadly as well.
Thank you so much, everyone. I just want to put that reminder in of that last slide. If you haven't received anything, you know, previously, or were unable to get a vaccine and you want a vaccine by Monday, you haven't received that information, then send over to me at that employee.engagement@vnahg email, and I will start to create lists so that we can get a pathway for you to get that vaccine as soon as possible. Thank you so much, everyone. What a great panel. Really interesting. Appreciate it.
Thank you, everybody.
Thanks, everyone. Be well.
Take care. Stay well.
Have a great day.